Thank you very much, Sin, for the very nice introduction. And it's a pleasure to be here. And I would like to thank Zespri and Juliet in particular, because we are friends. We met a few years ago in my office in Bologna. And when she came to my office, she said we should do a clinical trial looking at the effect of kiwifruit in patients with irritable bowel syndrome. And I thought that it was a crazy trial at the beginning, but then I realized that it was very interesting. And at that time, I knew basically nothing about kiwifruit. I knew that my kids loved it because they liked to eat kiwifruit. And I also knew that my mother-in-law told me always that when she ate kiwifruit, she could go easily to the bathroom. So I thought this probably is a good thing, even if I thought at the moment that your grandmother is always, your mother-in-law is always wrong. But then I realized that probably she was true, and I read a lot about kiwifruit, and I got a lot of information about it. And I found that the trial was indeed a good idea. So I accepted with honor that invitation to participate in that clinical trial. And I think that the presentation that I will make today will be an introduction to the results that will be presented later about the clinical trial. So I come from this university, the University of Bologna. They say that it's the most ancient university in the Western world, even if I think then when I see the dates in 1088, probably it was a coffee shop and not a university in those early ages. So basically what I would like to talk to you about is some general concepts about functional gastrointestinal disorders. And I would like to start with this picture. Basically, this tells us that about 60% of the people sitting in this room probably have gastrointestinal problems. These might be very mild, like constipation, diarrhea, bloating, and dyspepsia, or might be a little bit more disturbing. And these symptoms can be grouped in symptoms arising from the upper gastrointestinal tract, the esophagus and the stomach, or the lower gastrointestinal tract, the small bowel and the colon. So if you are symptom-free, probably you are in the minority. These are the American friends that looked at the most important diagnosis in outpatient clinics, and they found out that basically if we drew a line here after the 6th cause, we see that the first 6 causes of visits in the United States are for functional gastrointestinal disorders, namely abdominal pain, diarrhea, constipation, vomiting, nausea, heartburn, and indigestion. So these are very common disorders, and they have been grouped in several diseases here by the Rome Foundation, and these disorders are defined as symptoms arising from the gastrointestinal tract and not explained by any detectable disease. And they can affect the entire gastrointestinal tract, from the esophagus down to the anus. And you can see here in this picture that there are 2 conditions that have highlighted that are IBS and functional constipation, not only because we are talking about these today, but because they are among the most common functional gastrointestinal disorders. Unfortunately, these disorders are generally seen in this way. What's in a word? Functional. Functional is improperly used to indicate an idiopathic or cryptogenetic condition, and patients are labeled as neurotic, apprehensive, otherwise healthy individuals with an imaginary disease in their head, not a disease, not a true disease. I hope that at the end of this presentation I will convince you that now we know a little bit more about these disorders, and there are receptors, microbiota, changes in the nerves that we have in the gut that now we can identify in these patients. So these patients don't have an imaginary disease, but they have a true disease. This is the definition. I will not go through the details here, but basically what we should remind is that it's abdominal pain and discomfort associated with changes in bowel habit. This is probably funny for some of you. It's the Bristol stool scale. This is what we do in our offices. We scale the stools of the patients and we group them in different conditions. This is not just an exercise. This is very important because it has both physiological as well as therapeutic implications. And as you can see here, if you have for more than 25% these type of stools, type 1 and 2, you fit into the constipation category. If you have more than 25% of the type 6 and 7, you fall into the diarrhea part. If you have an alternation between constipation and diarrhea, you fit in the mixed bowel habit. This has physiological consequences because, as you can see here, the colonic transit time, the speed of the transit, is inversely correlated with the type of the Bristol stool scale, meaning that when the transit is fast, then the stools become more rich in water, and so this can cause, if the speed of transit is very fast, diarrhea, and the opposite is true for constipation. So here are our three groups: alternators, about 20 to 50%, constipation, 20 to 40%, diarrhea, 15 to 36%. And these are not stable categories. They change over time. It is easy to see that a patient with IBS with alternative type of bowel habit can go into constipation, and it is also true the other way around. Constipation, functional constipation, is another very common category, 15% in Canada, 14% in Spain, 10% in the US, and we keep it separate from IBS with constipation because the only difference is that in IBS we have pain, in functional constipation we have no pain. But now we know that this is more a spectrum rather than two separate entities, because it's easy to find that the patients with functional constipation sometimes have pain, and it's also easy to find patients with IBS with constipation that have very mild abdominal pain or discomfort. This is the epidemiology, the world prevalence of IBS, which is very high, around 11%. In Italy, we are here in green, so around 10%. In New Zealand, probably you have a little bit more, according to the statistics, 15 to 20%. Obviously, the prevalence depends on many different factors. I will not go into that. Some of these factors depend on even cultural or religional type of reasons, and some of these differences depend on also the questionnaires that we use to make the diagnosis. Basically, if we look at the incidence, two key factors appear. One is that this condition is more incident in females, and the second is that young female subjects are involved. So why young adults? We don't know, basically, but there are certain causes that we think that are important. People at that age move out, leave home, change diet, start a new job. start and end relationships. So we think that the psychological part of these disorders is important, and it's indeed important. Why women? I live in a family where I have 2 daughters, 1 wife, 1 mother, 1 mother-in-law, 2 sisters. So I did my little trial, and these are the results. So basically, women, we think that have a more complex bowel physiology. There are the hormonal influences of the sex hormones that modulate motility, sensitivity. So probably we have to look into that. But there are also, and we discussed this with Sim Fukudo this morning during breakfast, there are also genetic factors that are important in these changes. The consequence of these symptoms are the impact on the daily quality of life. You can see basically versus the healthy controls in blue, the patients with IBS have a poorer both physical type of quality of life as well as psychological type of quality of life. And it's very interesting to note that when we look at the quality of life of patients with inflammatory bowel disease, which are well-known conditions with inflammation and clear evidence of important inflammatory changes in the gut, then the quality of life is very similar. So they suffer the same. And it's very interesting to see that apart from the role of physical functioning and physical role, it's very similar, the quality of life of patients with IBS to that of patients with heart failure. So it's an important disease that has also important consequences on the money that these people spend for not only medication, but also hospitals, visits, and diagnostics, and many other things. And it's also an impact on the societies because these conditions are associated with a higher absenteeism and also a higher presenteeism. That means people that are sick and go anyway to work, but their productivity is very low. The mechanisms involved in the pathophysiology are basically along this axis, the brain-gut axis, and there are both factors that come from the brain and influence the function of the gut, and also factors that come from the gut and influence the functioning of the brain of these people. So it's a bidirectional type of interplay. And I would like to start with the top-down mechanism, which does not need a very recent publication because this has been known for ages. This is a publication from 1949, and Dr. Almi here with his collaborators was doing a colonoscopy to a patient, and at the same time they were measuring contractions in the colon. So at a certain point, they told the patient that, unfortunately, there was a serious disease. And what happened to the patients was that the motility increased, contraction in the colon, and the patient was very preoccupied. And then they told the patient it's only a joke, and motility went down to normal. Obviously, this is not feasible anymore because we have an ethics committee that tells us not to do this type of experiments, obviously, but this tells us a lot about this brain-to-gut axis and the influence of stress on gut motility. There are also peripheral factors involved. This is transit in the colon in hours, and you can see that basically compared to healthy controls, the intestinal transit time in IBS with constipation and functional constipation is lower, but not in the small bowel. And probably the problem is in the right colon as well as in the left colon, but not in the rectosigmoid region. Another mechanism that has been called to the play is visceral hypersensitivity, which is defined as a decreased threshold for perception of stimuli. And this condition can be easily reproduced in the laboratory by inflating a balloon, a mechanical stimulation of the intestine. This is basically done in general in the rectum because it's more easily accessible, but can be done throughout the gastrointestinal tract in functional gastrointestinal disorders. And you can see that a percentage of patients refers that they feel pain for a very low threshold of perception, which is lower than healthy controls. So these patients have visceral hypersensitivity, which is generated by an excessive input of information from the gut up to the brain. And I told you that these conditions now are considered microorganic conditions. These conditions are better studied now. There are changes in the microbiota, an influence of food, bile acids, and according to the current dogma, these substances can permeate through an epithelium that has an increased permeability and get down in excess into the lamina propria of the gut, where they stimulate abnormal responses there, including an activation of the immune system, which then communicates an abnormal signal to the nerves, to the little brain that we have in our gut, that generates abnormal patterns of motility on one hand and increased activation of those sensory fibers that convey information to the central nervous system. So I will, in the next few slides, talk a little bit about food and a little bit about microbiota by starting with this, that is the perception of the patients. What do they perceive about food and diet? They think that diet is much more important than medications in their management. And as you can see here, as we go down in this graph, alternative medicine is the last choice for patients, but diet is very important. So everybody now is on a diet, not only for IBS, but also for many other conditions. So you pick one and then you go. And what happens is that for IBS, now we have this new diet, which is the low FODMAP diet, which is very famous. It was introduced by Peter Gibson in Australia, very close to here. And basically, according to the papers by Peter Gibson, FODMAPs, which are fermentable oligo-D monosaccharides and polyols, skip the absorption from the small bowel, and they get in excess in these patients into the colon, where probably if you have an abnormal microbiota, then you get a lot of fermentation. And this generates gas and distension of the bowel, and in certain patients also diarrhea, and in others constipation. So this is based on a trial that Peter Gibson and his group have done in Australia. This is a randomized trial of low FODMAP diet versus standard diet. And basically, you see here that the low FODMAP diet is better than the standard Australian diet. There are many problems with these studies, and I will not go into the details about this, but one important aspect that we should also consider is that if we reduce the Mediterranean diet that was emphasized this morning, and if we reduce food containing fruit, vegetables, and these important stimulants for the microbiota, then what you can get is a reduction in the diversity of the microbiota, which is not good for health. So very strict low FODMAP diet could be problematic for some patients because they could induce this type of changes. So if you reduce everything, then what you're going to eat? What you should do is something that is written in the papers by Peter Gibson and others that have looked at this type of diets and apply it in a very good manner, which is substituting rather than eliminating FODMAPs, but substituting them with low FODMAPs diets. Good news for Zespri is that Kiwifruit is considered low FODMAP, so it can be easily introduced and replaced with the high FODMAP diets. Another point related to this type of diets is that probably you don't really need them. And this has been demonstrated in a recent study which has been published in Gastroenterology last year. And basically, Magnus Simren in Sweden looked at the effect of a low FODMAP diet and a traditional IBS diet, which is more concentrated on the regularity of meals, on the patterns, avoid large meals, the usual suggestions that the grandma can give us. Don't eat too much when you have a problem in your stomach. So basically what happened is that they randomized 75 patients to low FODMAP diet or a traditional IBS diet, and here are the results. Basically, no difference. So probably we don't need to go too much low FODMAP, and we just need to follow these very simple rules. Another point which has been emphasized this morning is that we should not avoid in these patients, because then what they do, they come to us and they said, you have taken away fibers, you have taken away coffee, you have taken away dairy products, you have taken away wheat, because now there is also this problem of the gluten sensitivity problem. So they ask us, what can I eat? Well, what we should do is to replace rather than avoid in these patients. And there are many good things that we could implement in the diets of these patients. So fibers, how do they work? There are many different mechanisms on the function of fibers in the gut. This is a very good review, American Journal of Gastroenterology 2013. And basically the main important factors is that for every 4 grams of fiber, for every gram of fibers, there is an increase in 4 grams of stool bulking. This is the important thing. There is stimulation of the microbiota, production of short-chain fatty acids, osmotic load. So these basically are substances that are very important for the health of our gut and for the promotion of propulsion in the colon. So basically for patients with IBS-C and the chronic constipation, a regular and increasing load of fibers, not too much, and certain type of fibers is good for their health. How do fibers work? Basically, they work because they stimulate this little brain that we have in our gut. This is the enteric nervous system. One sensory fiber here in blue senses that there is an increase in the distension of the gastrointestinal tract and transmits a stimulus in the oral part of this chain of neurons, which releases excitatory neurotransmitters, then the gut contracts, and transmit at the same time to these other chain of neurons other signals that release neuroactive substances that relax the gut, such as nitric oxide or VIP, for example. And so there is a gradient, and the intraluminal content can be pushed down in the gut. I said not all the fibers are good for these patients. This is a meta-analysis that is looking at soluble fibers and insoluble fibers. Basically, what we see here is that soluble fibers on global symptoms seem to be better than insoluble fibers. Not all the patients are the same. Those with no pathological findings, in other terms, they have IBS or functional constipation without changes, for example, in the anorectal region or a very slow transit, respond better to fibers than those that have those problems. What about kiwifruit? I will not go into details on this. It's just to set the scene for the next presentation, which will look at the effect of the new trials that has been designed. Just a few messages here. You can see kiwifruit in healthy controls and kiwifruit in patients with IBS. In healthy controls, there is an acceleration of the transit in the colon, but in patients with IBS and constipation, this reaches statistical significance. An increase in the number of bowel movements, an increase in the fecal volume, an increase in frequency, ease of defecation, and again, fecal volume. This is another study. So what we know about kiwifruit is that it's good for several reasons in these patients, and these studies suggest that this could be a good dietary suggestion for our patient with IBS. However, these studies have many problems, particularly in their design. So this is the reason why Juliet and the other group in the scientific committee of ZESPRI decided to go further and design a better trial. And I think that we will learn a lot about the results in the next presentation. Thank you very much.